Good afternoon, everyone, and welcome to Overcoming Disparities in Healthcare, the 9th panel discussion of the Digital Futures Flashpoint series and the first of 2023. Thank you for joining us today. I am Dr. Andrew Filak, and it is my honor to serve as the Senior Vice President for Health Affairs for the University of Cincinnati and the Christian Art Holmes Professor and Dean of the College of Medicine. The onset and height of the coronavirus pandemic made clear the disparities in healthcare and outcomes that residents of poorer communities in Ohio face. Today's discussion will illuminate the all too real life-altering challenges that impact many Ohio residents. As Dean of the College of Medicine, I'm proud that our graduating students are exposed during their medical education to the issues of disparities in healthcare. For example, all our first and second year students are required to take a course called Physician in Society. The most important objective of this course is to introduce future physicians to Cincinnati communities inhabited by their future patients and to teach the impact of social determinants of health on health outcomes. Our students receive firsthand experience by conducting a service learning project and obtain a unique perspective on health disparities that they carry with them throughout their lives as physicians. I know you'll be fascinated with today's important program. We have 3 excellent panelists with expertise on today's topic. Let me introduce them so we can begin the conversation. First, Dr. Bruce Vanderhoff. Dr. Vanderhoff was appointed Director of the Ohio Department of Health in August 2021, after having joined the agency as Chief Medical Officer in November 2020. He leads the effort to transform the landscape of public health in Ohio through programs and policies that strive to erase inequities, elevate the importance of social determinants, and improve healthcare and outcomes. Next, welcome Cara Dingus Brook. Cara is President and CEO of the Foundation for Appalachian Ohio. The foundation serves 32 Ohio counties in Appalachia by providing grants to nonprofits and works to build partnerships that help improve the Appalachian region's education, economic development, and environmental stewardship, and to eliminate health disparities. Also joining us today is Dr. Diego Cuadros. Dr. Cuadros is an associate professor of geography in UC's College of Arts and Sciences, and he is part of our Digital Futures program. He is a biologist and epidemiologist with strong mathematical and computational skills. He's interested in medical geography and quantitative epidemiology, and has studied such issues as disparities in COVID vaccination rates and the opioid crisis, among many others. Finally, I'd like to introduce our moderator, Jai Chabria. Jai has served at the highest levels of business and in government as senior advisor to former Ohio Governor John Kasich. Currently, Jai is managing director of the Columbus office of the public strategy firm Mad Global Strategy, and has served as the Digital Futures Flashpoint series moderator since 2020. Thank you for being with us today, and thank you to everyone online for your interest in this critical topic.
Dr. Filak, appreciate you doing the introductions. We really appreciate you being here. And, as Dr. Filak said, this is kind of a critical issue. What we do here on the Flashpoint series is we try to solve problems. We talk about how we can solve problems that matter. And I can't think of a topic that's probably more relevant to the state of Ohio and actually to America in general, just about what this kind of issue is. Look, I was doing some research, and there are some studies that show that there are over 700,000 Ohioans that live in deep poverty. These are folks that are affected by health disparities every single day of their lives. And this panel here is going to tackle that question today. If you have a question for one of our esteemed panelists, please either do one of 2 things. One, email us at research@uc.edu. That's research@uc.edu. Or you can drop it in the chat to Tony Almagor, who will be sending those questions my way. So please ask those questions as you hear the panels. We're going to get right into it. Diego, I want to start with you. You're a researcher here at Digital Futures. I want you to tell the audience a little bit about your research and how it applies to this topic.
Absolutely. Thanks, Jay, and thanks everyone for joining us in this very important discussion. So, as it was mentioned before, my name is Diego Cuadros. I'm an associate professor here at Digital Futures in the University of Cincinnati. In my lab, in my team, we're very interested in understanding the spatial structure of different diseases using different data analysis and visualizations with different digital technologies. So we're very interested in some diseases from different regions of the world. For example, in Africa, we study HIV, malaria, tuberculosis, but here in the US and particularly in Ohio, we are very interested in health challenges, like, for example, the opioid overdose epidemic and the current COVID-19 pandemic. As I mentioned before, we use these different digital technologies to try to understand the spatial structure and the dynamics of those diseases and try to identify these underserved communities or those communities that are being affected, heavily affected by those health challenges, as I mentioned before, the opioid overdose crisis and the COVID-19 pandemic. So again, those techniques that we use in my lab here at Digital Futures are the ones where we try to identify the dynamics, identify those drivers that are influencing the distribution and the dynamics of the disease, and again, try to identify these vulnerable, underserved communities that need attention. Thanks, Jay.
It's fascinating research. Dr. Vanderhoff, I was wondering, how did you come to this issue? What kind of like led you to this?
Well, not surprisingly, I have a perspective that I think aligns pretty well with that of Governor Mike DeWine. And like Dr. Filak, it's really informed by many, many years of experience with healthcare delivery right here in the state of Ohio. I have a background that really began in primary care medical education and with care in a lot of settings, whether it was mobile units, clinical care delivery in a primary care clinic environment, or even work in both rural and urban health. And from that, what I came to know is that it's imperative that every Ohioan has their best opportunity to achieve their best health. And if we're not mindful of providing that opportunity to every Ohioan, then we actually diminish every Ohioan's likelihood of realizing that goal. We cannot leave any group of Ohioans behind if we want all Ohioans to be successful in realizing their best health. The simple fact of the matter is we're in this together, and we need to address the issues together, because one way or another, issues that impact some groups and communities in our state will almost always spill over to impact all of us.
I mean, it's a really important point, and I think it's sometimes we have a myopic view, but I think one of the things that we're trying to do, especially with the panelists here, is try to how do we bring everyone together. So I appreciate you saying that. Cara, you come at this from a very different angle. You come up from philanthropy, and you represent some of the people that are most overlooked in our society. And it's been talked about a lot in media recently, but Appalachia is still a very tough nut to crack for people that try to. I'd love to just hear some like personal anecdotes about how health disparities actually affects real everyday Appalachians.
Okay, sure. And I think I'll just pick up where Dr. Vanderhoff left off, and that it takes all of us, because preparing for this, I thought, what do I have to contribute? I'm not a researcher. I'm not an MD. But if you really look at what's driving public health outcomes, 80% of the drivers are happening in the community, whether it's behavior and culture, or it's some of these other conditions that those 700,000 Ohioans you talked about battle. And so it's really something where we all can be leaders, because we all have influence on those community factors. So the Foundation for Appalachian Ohio is a regional community foundation. We serve the 32 counties of Appalachian Ohio. Just to put some color, as you were saying, to those disparities, in our region versus other parts of the state, life expectancy can be 10 years shorter. Our region's heart disease mortality is 22% higher. Our cancer mortality is 15% higher. Rates of overdose, suicide, depression, all of those things that sort of filter up to longer lifespan. So we don't believe that your zip code should dictate your health, and far too frequently it's a huge factor. How we come at these challenges is by something that I think is often underseen, which is addressing the philanthropy gap. So for those students on here that are learning about social determinants of health, I think this would be a great research paper, because we often look at the resources in a community to solve its problems. In Appalachian Ohio, we have 90% less philanthropic assets per capita than the rest of the state. And so that's 90% less grants and fellowships and funds to solve problems. And we're really grateful to Governor Mike DeWine and to the Ohio legislature that's been working with us to address this problem. We've now started community foundations across the entire region. Every county is served, and those foundations are partnering at more of a systems level change for healthcare. So thrilled to be with you today, Jay, and to talk about these issues. And we thank you for looking at populations like ours.
Well, those stats that you were rattling off, I mean, there's a lot of them. And sometimes, we got the State of the Union here tonight, and a lot of times they have a laundry list of stats, but people really need to hear what that is. Those are like real outcomes in people's everyday lives. So I appreciate you actually bringing those up. And yeah, those are things I would love for people to focus on. Dr. Vanderhoff, Cara represents Appalachian Ohio, a lot of rural population there, obviously, and these kinds of things affect rural populations. But there's also an urban divide, isn't there? And I was wondering if you could talk a little bit about how folks in urban areas have health disparities, because they sometimes don't have access to care. What are the similarities there or differences?
Yeah, that's a really great question. And I don't think people necessarily understand that fact, that there are real differences between the challenges that are faced in rural Ohio and urban Ohio. Just to carry forward a little bit more on one of the points that Cara made, rural Ohio also has a higher percentage of uninsured people under the age of 65 compared to our urban population. It's about 7.8% for rural, compared to about 6.6% for urban. And that's compounded by the fact that we also have a provider shortage that's more acute in rural Ohio. So if you look at our urban areas, there's a ratio of about 1,500 plus to 1 of people to primary care providers. If you jump to a rural area, it's over 3,000 to 1. And in Appalachia, it's actually over 3,500 to 1. So there's some big gaps there. But if we look at our urban areas, the problem is, while we have a lot of providers, we also, though, have urban provider deserts. So the provider population is just not distributed evenly. So it would be a mistake to look at those numbers and not recognize that we actually have a very similar challenge in healthcare delivery if we look at those urban deserts that we also see in some of our rural areas. But there are some things that are happening that really are making a difference. And I'll toss out one, because I think it points to some of the work that we need to do. And that is, here at the Department of Health, we've been supporting the growth in home-based visiting programs, and they're having a real impact. Now, what are they? Those are programs that are focused on expectant or new mothers, where they're able to receive regular visits from trained providers who are able to come into their environment and, importantly, not just point them towards the medical services that they need, but help address some of those social determinants of health that Cara referenced. Things like food insecurity, housing insecurity, their own safety. And our data shows that mothers who are enrolled in those home visiting programs, which we have targeted to many of these urban healthcare deserts, smoke less, they breastfeed their babies at a higher rate than the control groups, and crucially, these families have a lower infant mortality rate, much lower compared to their counterparts who live in those very same communities and have not been participants in that home visiting.
It's very interesting, and that infant mortality rate is certainly something that is an issue here in Ohio. It has been for some time, and I know that your administration has been tackling that. So thank you, Diego. I'm here in the Digital Futures building talking, and we are sitting here in a very urban environment in a mostly Black neighborhood. How does your research tackle urban versus rural? How do you think about that issue?
Yeah, that's a very important, a very interesting question to answer. We can maybe put this in context with the challenges that we are currently experiencing. Again, for example, with the opioid overdose epidemic, we can identify rural hotspots. Just if we focus in specific areas, we're going to identify those particular locations in which the mortality rate that is associated by opioid overdoses is higher. And then is when we can start exploring and trying to understand why we have this concentration of cases in these particular areas. And is when we can start seeing the emergence of these social determinants of health that are driving these kind of clusterings in particular areas. We can talk about poverty, we can talk about education, we can talk about many other factors. And that's when it's very important to identify these areas, because it's when we can answer the question about who is more vulnerable to the epidemic, for example. And also the question about where these people is located. And then why is people being more affected by the epidemic? And then is when we can start acting regarding those disparities. So we can identify these disparities, these differences between these hotspot areas and the not hotspot areas, and then try to act to reduce the disparities in these particular areas. And not just that, but also we can take other intervention measures, like, for example, implementing naloxone or something like that to try to reduce or try to avoid these overdoses. The same for the COVID-19 pandemic. We can see, of course, urban or rural differences. But for example, at the beginning of the pandemic, in the very early stage of the pandemic, it was the rural areas, the urban areas, the ones that were most affected by the pandemic. The population density was very important. We know that urban areas are more densely populated, and that facilitated the spread of the disease, the spread of the infection. But we knew, or the data suggested, that not everybody was at the same risk. Not everybody was at the same risk of infection. Not everybody was at the same risk of hospitalization and death that was related with COVID-19. So all this information is very important and help us to understand those disparities in urban areas. Later in the pandemic, we saw that the pandemic started moving from urban areas to rural areas. And is when rural areas and other differences start being more influencing more the course and the dynamics of the pandemic. But very early stage of the pandemic, we knew we were able to identify these important differences and disparities in urban populations.
So that's a real way that in just recent history that some of this research can help solve a very acute problem. Cara, let's stay on the pandemic since Diego brought it up here. When the pandemic hit, how were Appalachian communities hit? How were they affected?
I think that everything Diego said is true. I think it really put a bright light on the disparities that were here. The current state of health, the challenges with service delivery. I do think I just have to comment on the last part just a little bit. I do think there's differences between rural and urban, but I think there are so many commonalities between children or people living in poverty, and how it physiologically impacts your body, the mindset. And one of the patterns that we've seen, and it was even during the pandemic, was trust. How important it is that they trust the care, and that drives a lot of what we've seen. If I might just piggyback a little bit on what Dr. Vanderhoff said about your maternal health program, which is, as being a young mom, I think that's awesome. One of the things that we've been working on to address provider shortages has been a mobile vision clinic. And that clinic has now gone to 100 sites in Ohio. It screens children there, and it comes back later and provides free eyeglasses. I've met with young people, one recently, her name was Emily, and she was 12 and had her first vision screening on that clinic. She'd been suffering headaches. And I said, what'd you think about the headaches? And she said, I thought that's just the way it was going to be. Told me about reading and worksheets and things she was doing. That solution works really well in a rural setting, but it also works well in an urban setting. Part of the barriers we had to overcome was just a simple permission. I mean, there was a lot of money to be raised and clinics to be built, staffed, but the permission slip ways that schools function to allow care in the school. So I think there are patterns of similarity across rural and urban disparities that we can strengthen each other with our solutions.
So I think that is like one of the is just such a great point, because of these different, in the work that I've done, I've always seen that urban populations and rural populations, they do suffer from some of the similar issues. And if we can come up with solutions that work together, first of all, you're going to translate for each other, and then you're going to be able to come up with common goals and solutions. And I think that's perfect. And that's what a great program you guys are working on there too. I love that, the real world stuff that's actually solving problems. Diego, during the pandemic, vaccinations were a huge issue. I'd love for you to talk about that and comment a little bit about vaccinations and how we should think about that in the future.
Yeah, that was a very interesting dynamics where vaccination was implemented, when the vaccination campaign was implemented. So we can talk about the pandemic in two different phases: the pre-pandemic, the pre-vaccination era in the pandemic, and the post-vaccination era, which changes completely the dynamics of not just how the virus was transmitted, was spread, but also what kind of vulnerable populations were affected, because now we have a very important component, a very important external force that was changes the dynamic of the pandemic, and also changing the vulnerable populations during the pandemic. So when vaccination was implemented, I think that what Dr. Brook mentioned about trust was very important, and it's when we started also seeing a lot of variation in vaccination uptake in the country, which is very interesting. At the beginning of, actually, even right now, we can see that there are some counties that have more than 80% of the population fully vaccinated, and still some counties that are below 50%. So it's a huge difference, a huge changes in the vaccination uptake. One of the questions that we wanted to answer here at Digital Futures was try to understand why we have these differences, why we have these disparities. Most of the people were focusing on hesitancy, we're focusing on people don't want to get vaccinated. We wanted to look further, and we wanted to see if it was an association actually with healthcare infrastructure and access to healthcare and vaccination uptake. So these results were very interesting, because after controlling for, of course, vaccination hesitancy, we found that healthcare infrastructure, and access to healthcare was an independent factor that was associated with vaccination uptake. So basically, we found that counties with lower healthcare infrastructure were also counties with lower vaccination uptake. And more than 80% of those low vaccination counties were actually rural, which was a very interesting indicator of potential lack of infrastructure and access to care to able to be accessing the vaccination. So that's basically the work that we did and what we found, and tried to identify these disparities in vaccination uptake.
I appreciate that very much. And for those watching at home or in your office, please email us at research@uc.edu. That's research@uc.edu if you have any questions, or you can drop a chat to Tony Almaguer, who's on here watching out for us on the back end. Dr. Vanderhoff, I'd like you to talk a little bit about that vaccinations in the pandemic. It was an opportunity for the medical community to innovate, in a very short time frame. Talk about that a little bit, please.
Yeah, well, I'll tell you, it was a huge challenge, and it really required us to think outside the box. And it was, our response really depended on a very, very high degree of cooperation and collaboration across way beyond just doctors and nurses working together, but whole communities working together. And I won't go into a lot of detail around the infrastructure that supported that, but needless to say, we actually stood up infrastructure that we refer to as a zone structure that went well beyond anything that had existed previously. And it worked incredibly well. It led to many of the mass vaccination clinics that you may have seen in the news, et cetera. And while that was all wonderful, what I'd like to highlight is another effort that was made possible by that high degree of collaboration all across the state. And that was, we deployed 6 mobile vaccination units or vans. And those were targeted specifically to trying to reach those in communities with high social vulnerability and low vaccine uptake. And it was an example of that collaboration leading to a solution that really crossed the urban and rural lines. Because, just as Cara spoke about, what we found was that so often this was a problem which manifested itself disproportionately, both in that urban and rural area, not so much in what we would typically refer to as suburbia. And the importance of that, I don't think, can be overemphasized. Where did these vans go? Well, I mean, they went to places like grocery store parking lots in cities. In some of our rural areas, they went to the county fairgrounds. And in order for us to make these mobile units work, and they worked very well, it required us to partner with more than 100 organizations and agency partners. But ODH's mobile units ultimately have visited 128 different locations around the state, delivering more than 2,300 COVID-19 vaccine doses that wouldn't have been delivered otherwise. And went even beyond vaccinations, because they also were able to deliver a very substantial number of health screenings at that very same time. So people found out that they had maybe diabetes or high blood pressure or cholesterol issues that would not have known that otherwise, which led to a whole additional range of healthcare interventions and connection to primary care that were a fortunate byproduct of that community outreach.
So I want to ask a quick follow-up on that, Dr. Vanderhoff. So you talk about primary care where people don't know they've got the basic, so some issues that if they just went to their doctor, they would figure out by the testing. Is there a way to communicate that better to some of these communities?
Well, I think so. And we're extending some of what we've learned through the experience I just described into a whole variety of additional efforts, including seeking increased funding for some of those efforts. Probably the best example I can give is our school-based health programs. And in simple terms, what those are primary care extension programs, where we've recognized that the place in so many communities, whether they're urban or rural, that is a real integrated part of nearly every community, feels safe to the members of that community, and has real broad contact with both children and their families, are our schools. And so those school-based health programs are allowing us to extend primary care practices, family doctors, pediatricians, general internists, as well as our federally qualified health centers, essentially having branch offices operating out of the school. It not only is helping us to meet acute healthcare needs of children, so things we used to think of as school nurses taking care of, many of these schools don't have that functionality to a high degree anymore, coughs, colds, et cetera. But I think more importantly, basic primary care. And we're inviting in their relatives, so the people who are important to those children, to also receive their basic primary care there. So, if through one of these screenings, mom, dad, grandma, grandpa have been identified as having high blood pressure, diabetes, etc. Now they have a place that they can connect with and receive that care that frankly just may not have even existed in their immediate community previously.
That's fascinating. Okay, appreciate you answering that question too, because that it sparked something in me. I'm going to switch topics a little bit, and Diego mentioned touched on opioids. Cara, I'm going to start with you here. You know, opioids it's something that we see in the national headlines all the time. Clearly it's ravaged Ohio over the last 12, 15 years. But nowhere has probably been hit harder than Appalachia. You know, it disproportionately has affected areas of Appalachia. Do you believe the communities there are getting the support they need? And what more can we do to make sure that we're tackling this problem head on?
I think there's a lot of support on the way and a lot of investments we're really grateful for, especially in professional behavioral and mental health services, which there are huge gaps for. As you know, Jay, and I think this might be sort of where our paths crossed years ago, one of the things that we have worked on here in the foundation is actually investing in the community of support around the professionals. So, you know, the smaller nonprofits, the local Lions clubs, girls and boys clubs that are so critical as resiliency partners and support networks for communities. So I think, you know, I think we're moving things in the right direction. I see a lot of young people that are just so hopeful. You know, we've been funding a lot of youth-led prevention, and to see their leadership at this gives me a lot of hope. But I think we can't just professionalize the problem. There's a lot of value in community and in the connections and in the people that pick a child up at 10 o'clock on a Saturday night when they're in trouble, or bring the milk and eggs to the door when there's not the food in place. And we hear a lot of that from our grantees. So I think it's, again, maybe back to my first point, it's really all of us understanding the role that we all play in advancing the health of our neighbors.
And I think that's one of those little areas we talk about, rural and urban. It's that community aspect too. I think we bring back up here even on opioids. Diego, what do you think we can do on the prevention side for this opioid epidemic that we find ourselves in?
Yeah, this is a very complex epidemic, something very different that when we look at other epidemics like infectious diseases, let's say COVID-19. But there are some similarities. One of the similarities is that, like any other epidemic, not everybody is affected in the same way. Usually, these differences are coming from two sources. One of them is a bit more susceptible to the health challenge. The other one is disparities, the topic that we're talking about here. So those disparities are going to increase the risk of the particular health challenges. For this particular case, we're talking about the opioids epidemic. So one of the efforts that we are trying to do in order to overcome this situation is try to identify what are the vulnerable populations of these epidemics. What are the groups that are being more affected, demographic groups, which communities, where those communities are located. So for example, we are trying to keep track of the dynamics of the epidemic, and we are identifying that right now, the epidemic is hitting the hardest to the white male population, age 35 to 45, more or less, but the epidemic is actually growing really, really fast in the Black population, in the male Black population, pretty much in the same age. Other things, as I mentioned before, we can identify those hotspots that could be very important to introduce control interventions in those hotspots. But maybe the most important part in trying to identify these vulnerable populations is designing these control interventions with these populations, trying to identify why males have been more affected, and also linking with other factors. And something that we identify is mental health, as Dr. Brook mentioned. And what we see is this kind of synergy between other epidemics that could be, like, for example, mental health with the opioid overdose. So it's very important to understand that particular factor that maybe could not be correlated at the beginning, but now we're trying to understand way much better how these two potential epidemics, the mental health issue with the opioids overdose or the substance abuse disorder is associated is going to be extremely important, because now we can focus, for example, in trying to provide better services for mental health. That will be a very important strategy for the opioids or substance abuse disorders epidemic. So it's something that we're now very interested in trying to understand much better, this association, this link, and how to use that information in order to provide better services, not just controlling the epidemic, but actually providing better services for particular individuals in terms of mental health care.
Yeah, and the fact that it went from the white population, the white males, young males, really, to Black males. I mean, I think that's the kind of data that's really needed in the space to try to figure out how we combat this and prevent it. So I appreciate that. Dr. Vanderhoff, I know the DeWine administration is laser focused on this issue. I know that they have been since Governor DeWine took office 4+ years ago. Talk about some of the things that the Department of Health is doing and some of their counterparts in the administration are doing to combat this.
Well, as Diego mentioned, it's an incredibly challenging issue, not just for Ohio, but for the entire country. And it's complex enough that we could spend a whole conference just talking about this and not scratch the surface. At a high level, it's clear, as the other guests mentioned, that prevention really is essential, and prevention as early as possible. And I'll comment on that. But prevention isn't the only need. And one innovative and creative way that we're working to address the problem at hand is through our emergency department comprehensive care program. And what is that? Well, it's a frontline effort to increase screening, referrals, harm reduction efforts right in the emergency department, which, when people are coming to the emergency department and have perhaps just been resuscitated from an opiate overdose, it is very commonly a moment when, if we bring the right support and encouragement alongside them, we can have an impact that is profound. And it's a moment of vulnerability, but it's also a moment where we're able to cross so many of the divides that have been described, because when those overdoses occur and people land in the emergency room, they're coming to us from all walks of life. So this really is a level setting opportunity for us to reach so many communities and do it at a time when we know our impact is more likely to result in people making the choice to enter into recovery. Currently, those programs have a lot of features that they bring to the table, but one of the most exciting is peer counselors. So people who themselves are in recovery, they understand what that individual has just gone through, and they're able to come alongside, share that experience, and offer them not just encouragement, but somebody to come alongside them to begin that journey towards recovery. And this work is having an impact. Currently, the program's in 27 emergency departments, and to date, it has served almost 250,000 people. Wow. Who have the opiate use disorder, and has linked a very large number of patients to clinical care, other wraparound services that they need, and quite frankly, probably otherwise wouldn't have had. And the administration is leaning into, and if you look at the proposed budget, this is one of the areas that we are looking to expand because it is making a difference. And it's not just the peer counseling that I've described, but so many other services, including naloxone education, provision of naloxone to families and loved ones who may be able to then create another opportunity down the line if somebody doesn't choose to enter into recovery, save a life so that that decision to enter into recovery can happen on another day. But I'm also proud of our prevention efforts, and there is a lot going on through other agencies, including mental health and addiction services. But I'll link back to the school-based health clinics that I referred to before, because this is another area where their preventive efforts, I think, are helping us, because they help us to identify children at risk, especially children who may be suffering from mental health and behavioral challenges. And so we're very proud that this past March, Governor DeWine announced that our agency would coordinate $26 million in funding for 29 new school-based health centers. And again, as we're looking into the proposed budget, we're really looking to expand that effort as well. So I think that we recognize that this effort does begin with prevention, but we also recognize that we have a very large problem on hand, and there are a whole variety of interventions and support services to those with opiate use disorder and other substance use disorders that are vital and that we are working to enhance investments in.
So investing in things that are working is essentially what is the philosophy. So that's a really great point there. I'm going to go ahead and ask a question from the audience. And if you have a question, please email us at research@uc.edu. Cara, I'm going to go to you on this one here. The question is, can you speak about telemedicine, tele-health, and its growing role in Ohio and across the region?
Yeah, it's really, really a wonderful thing for communities like ours. A lot of people are using it. I think that the thing we have to be careful of is making sure that for those who are not comfortable with the technology, we have enough community health workers to be there to help them through that process. That's something we've certainly run into.
Okay.
I should also say, just Jay, we're on the funder side. We're not on the direct service providers, which is why I was encouraging students to go research the philanthropy gap and argue it should be a social determinant of health. Philanthropy has helped to start school-based health partnerships here in our region and many of the things we've talked about.
I love the interactive aspect of this too with you, Cara, trying to get our audience involved as well. So that's really important here. Diego, you want to talk a little bit about telehealth? What are the challenges there?
Absolutely. I think this is one of the highlights, or one of the elements that the pandemic highlighted. It changes our life drastically in many different ways. The way that we provide education, the way that we work. Actually, for example, right now, this is a great example in which many people from different parts of the city, of the state, of the world can connect and see our discussion. And of course, for health, this was a very important element to deliver healthcare. Right now, we think that actually telehealth could be a great solution for at least reducing some disparities, because again, it seems a very effective way of providing this type of care. But it's very important that before we expand these kind of services, we really understand how it works, and we really understand what kind of barriers we're going to face before we kind of like aggressively expand these kind of technologies, because we're going to see that some different challenges are going to emerge when we implement telehealth. Like, for example, internet connection is something is going to be very critical, that you have a good internet connection in order to have a good healthcare service. Another part, are you able and are you comfortable with using the technology? So we are talking about digital literacy, which is very important. For us, maybe this is something that is not a challenge at all, because we are very comfortable and familiar with any kind of technological device. But for many other people, particularly older people, this could be a very important challenge that we need to take into consideration. And actually the technological device that is able to connect you with the internet and to be able to access the digital healthcare service. So all are the factors that we need to take into consideration, because we want want to produce a solution for disparities, but maybe this kind of solution could actually exacerbate those disparities. For example, in the US, we're conducting some analysis, some data analysis, and we are seeing, again, a lot of differences in access to high-speed internet. Some areas in which connectivity is great, but some other areas in which connectivity is not really good. Surprisingly, actually, those areas with low connectivity, low internet connectivity are also areas with low healthcare infrastructure. So this is something that we need to take into consideration, and we need to design strategies in order to reduce these kind of problems. But absolutely, that's the way that we're moving forward. Healthcare services are going to become digital, are becoming very popular, those digital healthcare services. So it's very important that we are now in this early stage of this implementation of technologies, that we really understand what kind of barriers we're going to face in the future.
Thank you very much, Diego. We're getting lots of questions now from the audience, and I want to ask a few of those. So we're getting a couple of questions on partnerships. Cara, I'm going to come to you. This is actually directly for you. Can you speak to the challenges of working in an area that crosses multiple states, Ohio, Kentucky, West Virginia, in partnerships on these challenges, or is it not a challenge?
It can be an asset. It certainly can be a challenge. So we serve the Appalachian part of Ohio, but under our umbrella, we have 600 funds and 15 community foundations, including an African-American community foundation. So how do you handle that? In one sense, you need to be hyper-local in supporting things that communities need, but you also can play this role of scanning that region to find the bright spots, what's working that can be replicated. And so I kind of started this presentation rattling off statistics. That's usually not how we approach problem solving. We have a relatively small, though very generous amount of philanthropy that we could invest. And so how do you know where to start? We're looking for the bright spots, and our screen, our shorthand for it is SST. But the first thing we're looking for is something that's sustainable. The second thing is something that's scalable. And a third thing is something that's transformative. It might seem strange to start with sustainable first, but we have got to solve problems so we can move on to the next problems. And frequently, to sustain something, you need a public-private partnership. I mentioned the Mobile Vision Clinic. It's funded through Medicaid reimbursement. And I should give a plug to the University of Cincinnati, because we're also a pay-for-success program in the state of Ohio. And the University of Cincinnati is our evaluator. So you are a partner in making that happen. But once we raised the money, purchased the unit, hired the doctors, there was a path. And the Ohio Optometric Association and their foundation have been critical partners, as well as a national social enterprise called Vision to Learn. But you can only do things through partnerships. All these problems are bigger than any of us.
100%. We appreciate the plug too. So thank you for that. Dr. Vanderhoff, I'm going to come to you. So we got a question from the media. The media is actually watching this too. We are in Northwest Ohio and have a robust competitive healthcare system. How can we as a state work with these big healthcare systems who are doing great work to understand social determinants of health in urban settings? How can we get big healthcare systems to take part in these rural efforts? Any thoughts there with big healthcare systems?
Yeah, well, it's a great question, and I can tell you that we already are. So first, let me mention again our zone structure, which is really built upon our relationships with some of our big academic medical centers, who are then working with large health systems and individual hospitals all across their regions of the state. And that has just proven to be indispensable to us, both in terms of giving us frontline insights into the challenges on any given issue that we're trying to deal with, but also then in the coordinated deployment that I think makes a big difference for us. Now, I briefly, in one of my comments earlier, mentioned that in some of our work in Appalachian Ohio, for example, we've worked very closely with Ohio University. And that relationship has also proven to be huge in our ability to understand and address some of the issues in that part of the state. And I'll use it as an example because it's relevant to work that we're doing in other parts of the state, including in Northwestern Ohio. But for example, the work with OU, which is ongoing, has allowed us to help collate and put together very key information that informs our state health improvement plan. It's also helped us to look at health equity issues that are affecting that region of the state. And it's led to us understanding many of the interventions and solutions, including the mobile units that I described earlier that we've been able to deploy. There's another area though where our universities have been very, very helpful, and particularly our medical centers all across the state, big health systems have been helpful. That is an area that people may not really think about, and that is our wastewater monitoring network. We have that now distributed to more than 70 major watersheds in the state. And it all began and depended upon our partnership with some of the lab capabilities that existed first at the Ohio State University, but actually then moved on to our relationships with many other universities and academic medical centers in the state. And what I think is important about all of that is that we are working with those state universities in the Northwest Ohio, the University of Toledo for sure, but also the large private health systems that are so important in the care delivery in every part of the state, both to understand, but then also to develop interventions and solutions that make sense to them.
I think people, when you're giving those answers, I think they're gonna be surprised at the sheer volume of things that you do at ODH. It's pretty remarkable just trying to keep our citizenry healthy. So thanks for giving that perspective. We are running at the end of the hour, and I'm gonna have one more question. Diego, this is gonna be for you. Lots of stats thrown out there, lots of solutions thrown out there. We're at University of Cincinnati, a research institution. How do you look at partnerships? What do you hope to accomplish with some of the research, working with organizations like Ohio Department of Health, Cara's organization in Appalachian Ohio, or organizations across the state? How do you want to inform some of those solutions?
Absolutely. I mean, collaboration is the key for any research. Collaboration is the fundamental part of any investigation you want to do. And I think it's very important that we have these discussions, that we know the different perspectives, from the perspective of the funders, from the perspective of the donors, from the perspective of the public health, and from the perspective of the data analysis. So all these differences in the points of view of the same problem are going to be extremely important for solving exactly the same problem. So again, for example, here we have different point of views, different angles and perspectives of the problem, but we are basically trying to solve exactly the same problem. So these kind of collaborations in terms of, for example, data sharing, in terms of data analysis, are going to be extremely important for solving this kind of problem. So basically what we have here is a common problem with different perspectives, and it's extremely important, the collaborations, in order to solve these kind of problems.
Thanks a lot, Diego. I'm gonna, usually I just sign off and thank our panelists, and I'm gonna do that here. Cara Dingus Brook, Dr. Bruce Vanderhoff, and Diego Cuadros. But I'm gonna end with a comment that Sherry just messaged me. She said, "This has been one of the best panel discussions I've had the pleasure of listening to in a while. Great speakers who speak from the heart. Here's to more collaboration and working together to make all of Ohio better because of it." And then she mistakenly compliments me, but I'll tell you, but you folks really made it very easy. I really want to thank all of you for joining us. And for our viewers at home, I want to remind you that Research Innovation Week is going to be here at University of Cincinnati, March 20th to 24th. There's tremendous programming going on all week, so please try to come for some of that. That's March 20th to 24th. This conversation is going to be archived on our YouTube channel, so in perpetuity, so you could go ahead and take a look at it and share it along. And then the research students that are watching, you can get Cara's prompt to write your research paper too. Thanks all for joining us. We'll see you next time we do a Flashpoint series. Thank you.
Thank you.
Thank you.